This lady, around 50 years old, she's rheumatoid, had a bilateral primary knees 5 years ago or something, perhaps 4 years. There was a history of a delayed wound healing at that time, and now she has been complaining from pain, swelling. ESR is first hour 80, second hour 100, and CRP is 24. Torwell, any more further investigations to find out whether it is infected or not?
هو دلوقتي وجود الاي اس ار above 30 هو دلوقتي بقى لها 4 سنين عامله مش كده؟
نعم 4 سنين.
4 سنين عامله. فده احنا بنعتبره لو احنا هنشك يعني يبقى كرونيك بي جي اي، فعندها الاي اس ار above 30 اللي هو الكات اوف رقم بتاعنا، والسي ار بي فوق 10 اللي هو برضه الكات اوف. فاكوردنج للسكورنج هي كده واخده 3. فانا الفيرست لازم اعمل سكند immediate اسبيريشن وابعت الاسبيريشن، واستفيد من الاسبيريشن ده ان انا اشوف التوتال ليكوسيتيك كاونت قد ايه، نسبه البوليمورف في التوتال ليكوسيتيك كاونت، واذا كان معايا اعمل ليكو سايتس تريز تيست او الفا ديفنسن. كل دي ممكن تفيدني حتى في وجود النيجاتيف كلتشر، انما كانوت اكسكلود الانفكشن طبعا. الاذر اوبشنز ان هو يكون دي اكتيفيشن للروماتويد في وجود الاي اس ار العالي وللسي ار بي، وده مش هيقدر يفرق ما بينهم غير وجود الحاجات الماركرز الثانيه، التوتال ليكوسيتيك كاونت والبوليمورف.
تمام. حسام, this lady, we have already performed twice an aspiration of her knee, and we sent it for culture, both standard and extended, and we didn't find an organism. What is the next step up in the ladder for the excluding or confirming infection?
هو الحقيقه يعني هي بتبقى الحاجات دي صعبه قوي. دكتور وائل قال من شويه ان احنا بنعمل اذر لابوراتوري اكسبنسيف شويه تيست. ما اعتقدش الراديولوجيكال هتدينا جود انفورميشن، وخصوصا ما عندناش هنا السكان اللي ممكن يبين لنا في انفكشن ولا لا. بس
my residents, my team. And the lab that I always deal with, he's part of the team, the microbiologist, and he's performing these cultures all the time, standard and extended culture, and both negative.
ما عملتش وايت بي سي كاونت.
Please.
وايت بي سي كاونت وبوليمورف
White cell count was high actually, but I didn't rely much on the white cell count because she's rheumatoid. And usually the results with the rheumatoid patient may be different. لا synovium. I can't remember an exact figure, but I know from previous literature يعني طب ممكن الميكروفون بس عشان الناس تسمع؟
يعني هي سكند ستيب لو انا ستيل كويري اباوت ان ده كرونيك انفكشن يبقى سكند ستيب فور اوبن.
اوكي ابراهيم.
هو بس لو احنا الاي اس ار عالي والسي ار بي عالي والواي بي سي السينوبيال عالي، احنا كده السكور وصلنا
سكور وصلنا 6.
كده احنا كده بوزيتيف انفكشن.
الحقيقه انا فضلت ان انا اعمل لها برضو الالفا ديفنسين، ففعلا خدنا ديت كانت وهي في العمليات يعني بري اوبراتيف and it came positive. Yes.
يبقى احنا كده
now what would you do? Single or two stage? There is no organism. Okay. Okay. So
if we don't know the organism, I think this is an indication to go for two stages revision. But if we know the organism, yes, we can go for a single stage revision and replace everything one stage. But
Okay.
if we don't know the organism, we don't know who we are fighting.
True.
هو
Any comments?
يعني تصديقا لكلام دكتور طارق، هو without the organism is a contraindication for a single stage.
Okay.
بس knowing ان دكتور ايمن هو اللي بيقدم الحاله we have to consider a single stage.
No, this is not true. This is not true because there isn't, as I said earlier, it's not a hammer in the hand, and everything looks like a nail. There is
هو انا بس عشان
criteria.
نعلق على نقطه كمان ان لان في حاجات زي كده بتجيلنا اللي هو ويل فيكسد امبلانت وكرونيك انفكشن والديسيجن بيبقى ديبرايمنت وتشينج اوف ذير از نو رول اللي اتدار في حالات حتى لو ويل فيكسد امبلانت في الكرونيك بي جي اي.
That is another point.
لو اكيوت هيماتوجينس يعني جاي لك
This is another point. There isn't a rule for dare in chronic infection. الحقيقة ان انا I preferred ان انا go for two stage لان هي العينة دي is already on steroids. She is receiving disease modifying drugs. فالليفل of immunity في عينة زي دي is not the best. الحاجة الثانية فكرة ان انت to identify an organism following two separate aspiration from the knee joint and you haven't identified an organism would I wouldn't have a stand a leg يعني to stand on if I went for a single stage revision and it didn't succeed. فما كانش في داعي ابدا ان احنا نريسك someone who is 50 immunocompromised. We don't know what is the organism and consider a single stage revision. So we went for a two stage revision. This was the spacer. Dr. Ahmed, what do you think of mobile spacers?
I usually use fixed spacers because the mobile ones are somewhat expensive.
This is re-sterilization of the insert and the femoral component.
No, I just put a block with a nail inside and to keep the length between the femur and tibia. I know that if you use a mobile one, it's better outcome for the range of motion, but we don't have.
This is the point that I was going to ask you about. Don't you see that patients with fixed spacers have much less post-operative range of movement in comparison to those who have a mobile spacer?
Yes, it's better to have a mobile spacer, yes.
Okay. Brahim, you have the same concept, not to use a mobile spacer and you prefer the fixed spacer?
I use the mobile spacer in يعني 99% of the case whether hip or knee. ويعني I believe ان احنا if we're not using a mobile spacer we should have a reason not to use a mobile spacer. يعني لو عيان عنده مشكله في السوفت تيشو كفرج، عيان عنده مشكله في البون او في الاستابيليتي that might be an indication for a static spacer. Otherwise, I think there's enough evidence to support the use of mobile spacer in the hip and knee, articulating spacer.
الحقيقة ان الست ديت following the use of mobile spacer she was quite happy. In fact, she went back to work with a mobile spacer. And she was waiting to have the second stage performed. But unfortunately, the lady, 6 months down the line, she's fully active. She came back with reactivation of infection. Still infected. What to do?
أنا بس دكتور أيمن in those patients, immunocompromised rheumatoid patients, I wouldn't use any implants inside the knee بعد the first stage, and I would do a fixed spacer rather than putting an implant at that
Fixed
stage.
rather than a mobile.
At that
Okay.
stage يعني ده رأيي يعني. عشان كده يمكن ده حصل لها معرش ده طبعا ممكن يكون another reason of free infection يعني.
تمام. Do you think that there is a difference in the reinfection rate between mobile and fixed spacer as well?
I don't think so, but I have never used a mobile spacer. يمكن
Okay.
طارق نفس الكلام أعتقد. ده يمكن ده اللي بقالنا كتير على كده. We are successful في الإيه في الفيكسد سبيسر يعني.
Okay. Brahim, do you want to comment?
I want to comment لان هو في نقطه مهمه برضو في السبيسز. يعني احنا traditionally زمان كان ما احنا بنتعلم ان انت in between the two stage you should extend the period as much as possible. However, كل recent literature بتقول لك you should go as soon as possible for the second stage. لان بعد شويه السبيسر ده بيact as a foreign body that might harbor the residual infection. You should go for the second stage as soon as possible because it's another debridement and reimplantation.
Agree.
Maybe 6 اشهر دول يعني كانوا فاكتور من الفاكتورز اللي يعني ساعدت على الري اكتيفيشن اوف انفكشن.
Well, do you want to comment?
هي دي المشكله اللي ما بين الاستاتيك والموبايل. يعني الموبايل بيدي كونفيدنس للعيان انت از اوكي ويتاخر في السكند ستيج. الاستاتيك اوريدي هو بيبقى ستيف وان اكستنشن، فهو عارف ان هو ده مش الفاينل ديستنيشن بتاعه، فدايما بيبقى early to return. بس I don't know في statistically wise هل في فرق في الري انفكشن ريت بعد الاستاتيك فيرسس موبايل ولا لا؟ أعتقد
I'm not
مفيش.
sure, to be quite honest. Dr. Ahmed, now she came back with reactivation of infection. What would you do? Repeat the first stage or remove the spacer and consider fusion in the future?
She's rheumatoid, she's diabetic,
She's not diabetic, but she is rheumatoid.
not diabetic.
In steroids, she's on steroids
Steroid
and
rheumatoid.
disease-modifying drugs.
Gram-negative bacilli,
Gram-negative bacillus, yes.
I will go for fusion.
Okay. You don't consider redo first stage?
I am not optimistic.
Okay. Brave?
يعني at a certain point هنقول enough is enough بس I would reconsult the patient يعني هتكلم مع العيان على قد لو هو العيان طبعا فاهم اللي انا بقوله لو العيان is agreeing for another go I might because considering ان العيان is active considering العيان is relatively young age I might consider a second stage a third stage.
Third stage.
However at a certain point we have to say enough is enough يعني.
Okay. Well,
I will reconsider repeat the first stage.
repeat first stage, Hassan? Okay, we repeated the first stage. We did a fixed spacer this time. This was the level of debridement that was performed, and the patient stayed for 2 months before the second stage. And the second stage, we had a massive femoral and tibial defects. We used cones and we used an RHK in the second stage. But overall, this was a post-operative. In patients who are immune compromised, you cannot guarantee that a single debridement may work. In fact, up until now, I cannot guarantee that reinfection may be possible in the future. These are difficult patients to treat, especially if you have failed to identify organism at the beginning, you identified organism later on when you had tissues from the joint, but these patients in general are difficult to treat. There is a percentage of patients whom we call culture negative patients, whom we fail to define an organism even with a two-stage revision. And we know that the rate of recurrence in these patients with culture negative results is worse than those when we can identify an organism. So identifying an organism is an essential step. It determines whether you go for a single or two-stage revision. And even when you perform a two-stage revision, there is still a rate of failure of what you have performed as a first stage, and you may need to repeat it. Well, this is the end. If there is any comment from the panel.
How long is she now after the second stage?
4 months.
ربنا يستر. لأن هي 6 months get الانفكشن الثانية فربنا يستر.
We never know. Thank you very much.